Hello everyone, myself Dr. Siddharth Shah. I will present a video on transoral endoscopic thyroidectomy. Transoral endoscopic thyroidectomy is a novel approach for remote access thyroidectomy. Here, three mucosal incisions are placed in the vestibular space and dissection is performed in craniocaudal direction. It is an ideal scarless approach for benign thyroid and parathyroid lesions. Total thyroidectomy can also be performed in the same settings. Presenting a case of a young lady with a right-sided solitary benign thyroid nodule. Incision planning is done taking care of the ventral nerve anatomy. A central 10 mm incision is placed anterior to the frenulum and two lateral 5 mm incisions are placed anterior to the angle of mouth. The central incision is deepened into the submental space from where a subplatysmal tunnel is created, which is further expanded using blunt cervical dilator and hydrodissection to create the working space. Central 10 mm port for camera and two lateral 5 mm ports for working instruments are placed. The subplatysmal working space is maintained using CO2 insufflation at 6 to 8 mm of pressure to expose the strap muscles in midline up to suprasternal notch and laterally the sternocleidomastoid muscles. The strap muscles are then dissected in midline and exposed the thyroid nodule on the affected side. The thyroid nodule is mobilized from the strap muscle attachments of loose alveolar tissue. At this stage, a lateral tracking suture can be passed to retract the strap muscles laterally, and an anterior retraction suture can be placed at the level of thyroid cartilage to retract the anterior flap. The superior pedicle is identified and the vessels are coagulated close to the gland to preserve the superior laryngeal nerve. The vessels, if branching, are individually coagulated. This is followed by a more medial dissection in the avascular plane to expose the anterior tracheal wall. An energy device is very handy in this situation for dissection and maintaining the hemostasis. Pyramidal lobe, if present, is included with the main specimen. A midline isthmus is exposed and the isthmectomy procedure is completed. The superior release and the medial release of the specimen allows for adequate mobilization of the specimen for further dissection. A more mediolateral dissection into the Barry's ligament is then done to expose the recurrent laryngeal nerve. After identifying the nerve, a careful dissection of the Barry's ligament, maintaining and preserving the integrity of the recurrent laryngeal nerve, is done, which allows for further medial release of the specimen. Once the recurrent laryngeal nerve is identified, a true intracapsular dissection of the thyroid gland is then proceeded from a cranial to caudal direction, taking care of the supply to the parathyroid glands. The intracapsular dissection preserves the vascular supply to the parathyroid glands and allows for a very easy dissection of the gland. The vascular branches close to the thyroid gland is coagulated so that the vascular pedicle of the parathyroid glands are preserved. The inferior thyroid artery branch close to the thyroid capsule is coagulated and separated. The lower pole dissection is then proceeded to release the entire specimen. Coagulating close to the gland allows preservation of the inferior parathyroid glands. Once the specimen is released, it is placed in a specially designed endo bag to retrieve it transorally. Placing the specimen in the endo bag and recovering prevents any track recurrences and ensures complete removal of the specimen. A thorough saline wash to control and confirm hemostasis is then given, and the recurrent laryngeal nerve continuity is confirmed. The strap muscles can be approximated to cover the exposed trachea. The post-operative excellent cosmesis of the mucosal and the neck skin is well evident. Similar fashion, endoscopic parathyroidectomy for a benign parathyroid adenoma can be performed transorally. Herein, a case of an ectopic right inferior parathyroid adenoma is shown. Thank you.